Did you see the X-ray in the room? No, I don't think so.
Okay, I'll have to.
No. We will show you the X-ray. Yeah? I think it's always important to see the X-ray before you treat such a patient. And I'd like to show this to you. Can you fix it there that the cameraman shows it? So we asked the cameraman to show the X-ray of the esophagus. Please, and the light.
نور شغال.
I think it's okay. When you, even without the light, you can see.
مايل قدام شوية.
Yeah, so. Yeah, this one. Can you see the X-ray in the room? Yeah, it's okay, good. Okay, now you have seen the typical X-ray aspect of the achalasia. And please show the endoscopy picture now. Endoscopy picture now. Please transmit the endoscopy picture. Is this? Yes, okay, thank you. So I have introduced the endoscope already. I have been in the duodenum, which is normal. And of course, it's always important to make sure that this is not a tumor, but only achalasia. But the finding is very typical. It's a young girl. Since 6 years, she complains from dysphagia, and which is also a little typical. When I went through the endoscope, I had a little resistance. And typical for the achalasia is the only situation where you cannot induce a hernia by insufflating a lot of air. This is a good sign that this is a achalasia. And you see, I have insufflated a lot of air now, and there is no hiatal hernia. That is a typical sign, and I also have no sign of a tumor, so I think the diagnosis, there is no doubt that the diagnosis is correct. And now we will treat the patient with a balloon dilatation. I introduce a guide wire, a Savary wire, which is a little stiff. And now I go out and I show you the esophagus, which is dilated and contains some food residue. We are here in the cardia, as you can see. There is no tumor, and I have a little resistance when I go through the endoscope. And now you can see, which is a typical finding for achalasia, that there is some food residue in the esophagus, very typical. And you see these tertiary contractions, these the non-peristaltic contraction rings, very typical, and also the dilation you can see here in this region is very marked. So no doubt concerning the diagnosis. We leave the wire inside and we remove the endoscope now to prepare balloon dilatation. Yes, and the anesthesiologist is sucking, evacuating the mouth, which is very wise because in this case it's with fluid in the esophagus. It's always wise to aspirate to prevent endotracheal aspiration. Okay? Please, you hold the wire. Okay? Hold the wire. Okay? Good. Okay? Okay, I hold the wire. You have to put the endoscope, please. Is okay? Okay, good. Okay, when you use the Savary wire, you always have to pay attention to your eyes when it goes out. So now we take the balloon, which is a 3 centimeter balloon. It's a cylindric balloon by Wilson Cook. And what you can see here, which is important, the balloon has a flexible tip, and it has 3 markings on the inside, and they serve as orientation markers when we are inside the stomach with a balloon. And some people perform this procedure under fluoroscopic control. I think fluoroscopic control is not necessary, and I prefer endoscopic control alone.
Excuse me, sir. Can you hear me there?
Yes.
Well, you see, I'm a surgeon. You know, I do this achalasia laparoscopic surgery for the achalasia. I mean, do you see the indications for surgery here, or you?
Well, that depends on the further course. I think balloon dilatation is the method of first choice, and if we are satisfied with the clinical course and get the patient free of symptoms, we continue. If not, she is a candidate for surgery. Maybe one day later on, but for the first choice, I think we should prefer the minimal invasive technique with balloon dilatation.
I still speak about minimal invasive technique, which is laparoscopy, and
yes.
I mean, I believe that the recurrence after balloon dilatation is quite high, you know.
Yes, but also the surgical procedure is not 100% successful. So I think, and speaking of minimalism of the intervention, I think this what we do is more minimal than surgical minimalism for the moment. But I'm absolutely open for this alternative, and I think we have to make a good differential therapy indication.
Well, I can't disagree with the minimality of what you're doing versus surgery, but what I'm speaking about is the efficiency and the incidence of reflux after balloon dilatation.
Yes,
what do you see about that?
Yes, of course there are relapses, and you never know before in the individual situation. And the policy is to treat the patient, to follow him up clinically, and some patients need re-ballooning every year or every 3 years, and we expect normally the first series of treatment. Normally we need 2 or 3 sessions even, in a 1 month interval or so. And if then we have a good result, we follow them up by observing them, and if the patient is satisfied, it's okay. And if the intervals are too short, one can combine it with botulinum toxin injection or decide for surgery. So I think in the individual case that is the right policy. Okay. Well, I introduce the endoscope again. The balloon is now in place, and we have the balloon should be in the stomach now. No, it is not. Okay, hold the endoscope, please. I have to introduce the balloon more deeply. No, not yet. I introduce the balloon more towards the stomach. I will check again where we are with the endoscope. You hold this. Okay, now the balloon disappears in the stomach, and now the nurse pulls the balloon back. There's a lot of friction between the endoscope and the balloon always. I pull the balloon back into the cardia, okay. That is the right position now. And now the nurse is kind enough to inflate the balloon while we check the position from here. Okay, inflate the balloon to maximum, please. Okay. And this is a moment which is very important. There are 2 things which are important. One is that the balloon sometimes slips into the stomach or back onto the esophagus. So we have to check stop, release again, release, release, release. Now I slipped in the stomach a little bit. I have to go back a little bit. Now inflate again, again. And this is sometimes a little delicate, but I think in this case it's okay. We have a stable position now. Okay, maximum, maximum, wow. Yes. Yes. And what is the other thing which is important, that the patient has a good deep sleep.
Excuse me, what's the pressure you use for dilatation?
This balloon tolerates 45 psi, that is 3 atmospheres. And
we can't hear you now.
Where's my microphone? Well, this is really... Hello? Okay. Well, this balloon tolerates 45 psi, which is 3 atmospheres. We have a little weak pump here, but we go to the maximum, and that is different from product to product.
How long do you keep it there?
Only short time. There's, in many textbooks you find that you should leave it inflated in place for 2 or 3 minutes or so, but this has never been proven, and in my opinion it's not necessary. And I tell you why. Because I want even to reduce the time with the inflated balloon in place, because while the balloon is inflated, there's always the risk that the patient has a hiccup. And this is the dangerous moment. And we want to avoid this situation that the balloon is inflated to a maximum and then the patient has a hiccup, because this is the situation where the perforation occurs. And this is the reason why I keep the inflation only for a short moment and repeat it, and why I prefer to have a deep sleep, and this is the case in this patient. And now I want to show you one more thing. When you have the problem of slipping of the balloon back to the esophagus or in the stomach, you can do the following. If you do the procedure in retrovision situation, then you can fix the balloon very, very nicely in its position. And I try to show you this. I will show you. And in addition we have, give me the microphone here, this. And in addition we can add some to the effect, because if we inflate once again, we have a 30 millimeter diameter of the balloon plus the 1 centimeter diameter of the scope. And here you can check very nicely the position, as you can see here. Here's the whitish tip, and then you have the ring markers here, which you can see on the blue central sheet. And now again we can inflate. And you see now the position is fixed very nicely, and it cannot slip into the stomach nor in the esophagus. And you can control the release a little bit, release a little bit, release a little bit, release a little bit, okay. And if you see a little blood, like in this case, this is absolutely okay. This is a sign of efficiency and not a sign of perforation or complication.
Do you have any objective measure, of the LES pressure during this procedure?
No, you have not. You have only the clinical cause. Okay? Now you can release again. Okay? I think this is enough. I wanted to show you this little trick to fix the balloon in a nice manner so it never can escape when you're in this position, because the friction between the endoscope and the balloon is very high. And I think for the first session, which we have done now, it is enough. You see there's a little blood on the cardia, but this is normal. I think we stop the procedure here. It's finished, and